Another common one that comes up often is using ultrasound for certain procedures in ICU. And it used to be that ultrasound, there is an item 55054, which is two-dimensional real-time ultrasound for procedural guidance, essentially. And this item used to be used, originally was used by interventional radiologists. And then when ultrasound came into general point of care practice in intensive care, in anesthesia, in the emergency department, um, they people started using this item number to account for the fact that they were using ultrasound to do percutaneous procedures, to central lines, arterial lines, chest drains, and the like. And back in, I think, 2014, actually the MBS quite clearly said that this is now becoming standard of practice, and they stopped the anaesthetists altogether from claiming this item. I'm not entirely sure why they only stopped the anaesthetist. I presume when they looked at their numbers, they were the group that was claiming the largest amount of this item per procedure or claim that they were doing, because presumably they were using it for all the lines, all the nerve blocks, everything that gets done in anesthesia. So there was a ruling that said that for anesthetic procedures, you're not allowed to claim 55054 at all, ever. ICU and the emergency department radiology continued to use this item to claim for percutaneous procedures. And then when the most recent MBS review came around looking at intensive care items, they did a ruling which said that this is now standard of care for percutaneous vascular access. So they have removed the item from being co-claimed from central line and arterial line placement, and they have actually built this into two new item numbers which came out at the same time, which is VV and VA ECMO placement. So those descriptions in the MBS now include any ultrasound guidance that gets used for those items. The recently updated item number for ventricular assist devices, which relates to putting in a left-sided impeller, also clearly it's actually gone a bit further and states that all intraoperative imaging is excluded from that item number. So you can't claim ultrasound for the percutaneous puncture if you're doing a percutaneous procedure, but also you cannot claim any use of image intensifiers in theaters, or a TOE or a TTE that gets done to position the device. So by the definition of that item, it's now all included. There is a bit of inconsistency because it's only those items that they have said that we cannot claim procedural ultrasound for. So all other procedures where you might use ultrasound guidance, so doing percutaneous procedures for chest drains, for abdominal drains, tracheostomies, lumbar punctures, pericardial drains, so anything else you can think of where an ultrasound might be used, it can actually still be claimed, with the caveat that it is a bit problematic, because the way the MBS or Services Australia has set up their rule revisions, they actually made it very simple for themselves. So they just block every ultrasound item that gets claimed in correlation to one of those vascular access items. And where that becomes a problem is when you start doing diagnostic ultrasound. So if you say, put a central line into a patient and claim an item for that, but you happen to have done an echocardiography or an abdominal ultrasound, or something completely different, those items will bounce as well. So you've got to be very mindful that claiming ultrasound items nowadays with intensive care procedures, or a lot of the intensive care procedures, need to be very clearly annotated and marked, and the service text has to be very accurate. Otherwise, you're probably going to be looking at a rejection. But the short answer really to the common question that gets asked is that, unfortunately, for quite a few years now, you're not able to claim procedural guidance for vascular access. I mean, I must add that they didn't just take that item away. They have actually indexed the fees that we can claim for those items quite substantially. So overall, I don't think that was a loss, and I think it was a reasonably fair call to say that that's now standard of practice. So that should be the expectation.